Good evening, friends. Let's discuss psychiatry questions. We start with question number 1. Reena, a 25-year-old female, present to psychiatry OPD with complaint of rapid heart rate, shortness of breath, trembling, and sense of impending doom. I highlight this phrase, sense of impending doom. In psychiatry, particularly anxiety disorders, many times you will find phrases. And if you find a particular phrase, you will find answer. Just like feeling of impending doom, immediately I will think about panic attack. Panic attack. Okay. Before making the diagnosis of panic attack, very good evening, we will do all investigations. All investigations should be normal. Okay. Yes, she feels like she is losing control, fear that she might die. These episodes last for 10 to 15 minutes, means episodic anxiety is there and usually happen multiple times a day. What is the first line of drug treatment? So first of all, diagnosis is panic attack. Multiple time panic attack are occurring, means panic disorder. Panic disorder means multiple or recurrent panic attack for more than 1 month, panic disorder. So this is panic disorder. In panic disorder, the treatment is combination of CBT plus SSRI. Best treatment is CBT plus SSRI. Most of the questions of treatment, you will find answer CBT plus SSRI, golden rule of psychiatry. All anxiety disorder, yes, generalized anxiety disorder, CBT plus SSRI. Panic attack, panic disorder, CBT plus SSRI. But in phobia, behavior therapy plus SSRI. Okay, so all anxiety disorder, CBT plus SSRI, except phobia, where behavior therapy plus SSRI. Good. So in this you can easily mark the answer SSRI because they have asked first line drug, means drug of choice. Don't get confused by the first line drug and initial management or immediate, better to say not initial. Yes, it would be confusion. Immediate management. Okay, means patient came to you in psychiatric emergency and patient is having panic attack. What is the immediate treatment? Okay, then you will give benzodiazepine. But first line means drug of choice. Okay, so in this benzodiazepine is not the answer. Low dose antipsychotic can be given in panic disorder to augment the effect of SSRI if patient is not improving with SSRI. So it is not used as the first line. Mood stabilizer not given. So answer is SSRI. So let me describe it in little bit detail. Yes, a patient is sitting, suddenly start having palpitation, breathlessness. He will think that he will die, he will go crazy, my doom day has come. So wherever you find this phrase, my doom day has come, I will die, I will go crazy, episodic panic attack. And multiple panic attack, recurrent panic attack for more than 1 month, panic disorder. In the same way, you may find in few questions free floating anxiety. If free floating anxiety is there, without second thought, the answer would be generalized anxiety disorder. Duration criteria is 6 months. G looks like 6, so 6 months. And treatment is CBT plus SSRI. CBT plus SSRI. Second question. A patient of schizophrenia treated with first generation antipsychotics for 5 years. Yes, whenever a patient of schizophrenia came to me, I started with second generation. What is the reason we are preferring second generation? Yes, guideline says that we should start with second generation. Okay, but in this question they have given first generation. Why we are avoiding first generation? The reason is that it causes more extra pyramidal side effect, EPS. First EPS, earliest EPS is acute muscle dystonia, means I gave first generation antipsychotic haloperidol. Most of time question you find not first generation haloperidol. You gave haloperidol. In the evening, patient came with twisted neck, lockjaw, uprolling of eyeball. That is acute muscle dystonia. This is earliest EPS and the treatment is injection promethazine. Recently asked question. Suppose this patient is maintaining well on haloperidol. After 2 weeks, patient came, says, Dr. Saab, I am having restlessness. I am feeling restlessness. Means subjective restlessness. And family member told, Dr. Saab, he is not sitting at one place, he is roaming around in the home. So that is subjective and objective restlessness. That is akathisia. That is most common EPS. And the treatment is beta blocker. Okay. Restlessness मतलब बेचैनी, B4 बेचैनी, B4 बीटा ब्लोकर. ओके. मसल डिस्टोनिया, आंखें पलट जाएंगी, P4 पलट जाएंगी, P4 प्रोमेथाजीन. ओके. Tardive dyskinesia, if a patient is taking antipsychotic for a long time, yes, antipsychotic for a long time, then he may develop he or she may develop perioral movement. Just like an old person without teeth, you must have seen. But if a 30-year-old patient taking antipsychotic for last 5 years, sitting in bank manager, and whenever a lady comes and he will be bitten daily. So that definitely it is very disturbing side effect. Why I told you this story? The reason is that you will remember that tardive dyskinesia is a very disturbing side effect. This is due to upregulation of D2 receptor. Yes, upregulation. So perioral movement sometimes, yes, look at me, looks like rabbit syndrome. Okay, and treatment is stop antipsychotic and give valbenazine, tetrabenazine. FDA has approved valbenazine. Question may be asked. So these are extrapyramidal side effect. The last EPS. So answer is A in this question. Very good. Fareen. Answer is A. Last point, many times questions are asked on neurolapse malignant syndrome. Neurolapse is old name of antipsychotic. Malignant, anything which cause death is called malignant. You gave antipsychotic. Patient developed fever. Yes, D2 blockage. Antipsychotic cause D2 blockage. Fever may be there. Yes, muscle rigidity may be there. If muscle is rigid, then there would be muscle cell lysis. Myoglobin will be released. That will be excreted by kidney. Kidney would not be able to handle such a large amount of myoglobin. Kidney failure. Most common cause of death. Yes, acute renal failure. Yes, muscle rigidity, muscle cell lysis, myoglobin increase, excreted by kidney failure. If muscle cell lysis, potassium would be released. Potassium increased. Yes, affect heart. Second most common cause of death, cardiac failure. Muscle cell lysis, increased CPK. So this is neurolapse malignant syndrome. Drug of choice, question is asked, dantrolene. So in this question, answer is tardive dyskinesia. Third question. Yes, please do reply. What is the answer? Yes. 19-year-old female present to clinic with history of significant weight loss, restrictive eating habits. She reports a fear of gaining weight and intense desire to maintain low body weight. She restricts her food intake, avoids certain food groups. She constantly monitors her weight, body shape, food intake. Means eating disorder, it is very simple. Yes, her BMI is calculated to be 18. Okay. Psychological evaluation reveals a distorted body image, excessive exercise, social withdrawal. She denies experiencing binge eating or purging behavior. So binge eating, purging is not there. So no bulimia nervosa. Yes, no binge eating purging, no binge eating purging. So these two options ruled out. Yes, this is anorexia nervosa. This is anorexia nervosa restrictive type. Let me simplify these clinical questions with the help of flowchart. You will find so many questions and may get confused. So simple technique is, if a question is asked on eating disorder, first of all you will look for patient is taking large amount of food or less amount of food. If a patient is taking less amount of food, you will search for reason. Suppose a patient is taking less amount of food, eating less, and patient is eating less because don't like the taste of food, don't like the smell of food. What I said, don't like taste, don't like smell, means patient will avoid, patient will restrict the food because of taste or smell. That is called avoidant restrictive food intake disorder. Yes, this is the eating disorder which is equal in male and female. All other eating disorder are more common in females. Okay. So if patient is eating less, yeah, that is avoidant restrictive food intake disorder, if not liking taste or smell. If patient is having body image disturbance, okay, then anorexia nervosa restrictive type, anorexia nervosa restrictive type. If patient is taking large amount of food, that is binge eating, and followed by purging, yes, followed by purging means try to compensate, yes, induce vomiting. When they will induce vomiting, there would be callus on the knuckle, Russell sign, okay. Then if purging is present, two answer may be there, either bulimia nervosa or anorexia nervosa binge eating purging. How you will differentiate? You will differentiate based on BMI. Means if binge eating and purging is there, in this question no binge eating purging, but if question is asked binge eating purging is there, first answer which will come in your mind should be bulimia nervosa. But if binge eating purging is there and they gave that BMI is less than 18.5, yes, according to ICD-11 18.5, yes, according to ICD-10 17.5, ICD-10, okay. So if less than 18.5, anorexia nervosa binge eating purging type. Got the point? So in anorexia nervosa, few questions let me discuss. Anorexia nervosa BMI is less than 18.5 according to ICD-11, okay. So in this is one catching point. Okay, restriction of diet, patient is taking less amount of food. In this, yes, please do comment. Loss of appetite is there or not? Loss of appetite present or not? No, there is no loss of appetite. I write here no loss of appetite. This is misnomer. Anorexia means loss of appetite. This is misnomer. There is no loss of appetite. Okay. Now, so this question, very simple question. Yes, this can be easily ruled out because in avoidant restrictive food intake disorder, patient is not taking food because of taste of food, smell of food. Okay, got the point? Very good, Fareen. Now, next question. This is really difficult question. Okay, confusing in fact. Yes, a 38-year-old male present to psychiatric OPD with perplexing issue. He describes an overwhelming fear of contracting deadly disease. मैं highlight कर रहा हूँ, I am highlighting. This is deadly disease from everyday objects, just such as doorknobs, elevator buttons. Okay. So one thing they have given this deadly disease. Now this is telling you ritualistic hand washing. Yes, answer is OCD. Very good. Ritualistic hand washing, convinced that he will contact with illness. Okay, intrusive thoughts are there, causing harm to loved one. So in this, the confusing word is deadly disease. Sometimes we discuss in hypochondriasis, patient is having fear of deadly disease. Yes, before giving the description of OCD, definitely in this answer is OCD. But why I am giving stress? Because similar question you may find. with the deadly disease. Let me describe. Suppose a person came to you saying that Dr. Saab, please do check. I was having yellowish discoloration of urine. You know, it occur in jaundice. Jaundice occur due to liver disease. Liver may have cancer. That's Dr. Saab, I may have this deadly disease, liver cancer. So, in hypochondriasis or illness anxiety disorder, patient is concerned about deadly disease. But in hypochondriasis, patient will go to multiple doctor, multiple investigation would be done, and doctor will not find any sign. Everything would be normal, and patient is concerned with diagnosis. Then the diagnosis would be hypochondriasis. Okay. So, DSM-5, the name is illness anxiety disorder. Hypochondriasis, the name is given by ICD 10 and 11. Okay. So, in this recurrent intrusive thoughts are there, definitely the answer would be obsessive compulsive disorder. Hypochondriasis I just described. Schizotypal personality disorder, yes, in this there is odd and eccentric thinking. Yes, magical thinking is there, magical thinking may be there. Okay. Body dysmorphic disorder, patient is concerned with personal ugliness. Typical question on ask on body dysmorphic disorder. There is a lady came to OPD, say, Dr. Saab, you know, my nose is a little bit larger. Yes, I want to get operated. Actually, she is having these thoughts again and again. Okay. And when she is counseled, she would accept, okay, that my nose is normal. But these thoughts will come again and again, and that's why body dysmorphic disorder is part of OCRD, obsessive compulsive and related disorder, obsessive compulsive and related disorder, OCRD. Now, last question, really important topic. I have already told you many times in psychiatry, only one word is sufficient to find the answer. In this question, if I see confusion, severe confusion, disorientation, without second thought, suddenly, yes, suddenly, acute, I write here, acute disorientation, acute confusional state, yes, SK, then sir, this person, what we need to do? In this, yes, body dysmorphic disorder or which one? If OCD, the treatment is ERP, exposure and response prevention, ERP, exposure and response prevention, plus SSRI. Okay. So, question is asked in OCD, the best treatment is exposure and response prevention, better than ERP is better than CBT. Question is asked. Okay. So, don't get confused. Okay. Yes. So, golden rule of psychiatry. In most of the psychiatric illness, yes, I write here, golden rule of psychiatry, CBT plus SSRI. Yes, if I ask you anorexia nervosa, CBT plus SSRI, bulimia nervosa, CBT plus SSRI, generalized anxiety disorder, CBT plus SSRI. Yes, hypochondriasis, CBT plus SSRI. Okay. So, got the point? Now, I came to this acute disorientation, acute confusional state, yes, acute confusional state or clouding of consciousness, clouding of consciousness. If these words are there, without second thought, the answer would be yes, delirium. Although to say delirium, multiple things are required, but for your question purpose, acute disorientation would be there, and without second thought, you will mark the answer yes, delirium. In the same question, in this answer is See delirium. In the same question, if I write the patient develop these symptoms after, okay, with a little bit modification, and I say develop after stopping alcohol, the answer would become, yes, please do reply. Answer would become delirium tremens. So same question, if delirium occur due to withdrawal of alcohol, the answer becomes delirium tremens. Got the point? Now, delirium tremens, the treatment is IV lorazepam plus IV thiamine plus IV dextrose. Point it out, thiamine is given before dextrose, frequently asked question, thiamine is given before dextrose, okay. In delirium, the treatment is treat the cause, delirium, treat the cause of delirium and low dose antipsychotic. Now, I discussed this question little bit in detail. 80-year-old dementia may be there, yes, but patient develops pneumonia and develops severe confusion, restlessness, disorientation suddenly, means acute, okay. Dementia duration criteria 6 months. So, disorientation may be present in dementia, but duration 6 months, okay. Yes, he thinks he is at home and complains of insects attacking him. So this is hallucination. This may be hallucination, this may be delusion, they have not described in detail. This may be, if he is feeling sensation of insects attacking him, then it is tactile hallucination. If he is visualizing insect attacking on him, visual hallucination. If he is having firm belief that I am having insects crawling, yes, that is thought delusion of delusional parasitosis may be there. But it is not so important to differentiate between dementia and delirium, okay. The main concern in this question is severe confusion, and I mark the answer delirium, okay. So one more question which has been asked, that delirium is most common organic mental disorder. This is most common FMG question, most common organic mental disorder. Second question, that in delirium there is fluctuating course, sundowning phenomena means symptoms worsen in evening, So remain positive during this last phase of preparation, because exams are near. Anxiety will develop, little bit anxiety will develop, that is beneficial. But if anxiety goes beyond a point, your performance will decrease. So during this period, just adopt belief system. Yes, this is very important system in psychiatry. If you do believe that I can do, you can do, okay. All things are determined by our thinking. So if you think that I will clear this exam, you will clear. So belief system in psychiatry, if I have worked since morning to evening, yes, I will clear this exam. So best of luck, remain positive. Thank you. Okay.
Good evening everyone. I hope everyone is doing well. Good evening everyone. I hope everyone is doing well. Let us start with the CBoT discussion of pediatrics. So I hope everybody I hope everybody did the questions of pediatrics all correct. They were very simple, straightforward questions, and I hope the same type of questions will come in your main exams also. So wishing the very best of you, best to all of you. Let us start with the discussion of the questions of pediatrics that came this time. So the first question was, during a pediatrics viva, a student was given 4 statements out of which he was asked to select the most appropriate one. Which of the following statements would have been chosen by him that the examiner was satisfied with the answer? And the statements were: birth weight triples by 2 years of age, the infant measures 90 centimeters at 1 year of age, the head circumference becomes equal to the chest circumference by 6 months of age, or for the first 3 months of life, weight gain occurs at a pace roughly 20 to 40 grams per day. Right? So this, which is the, basically they are asking you which is the correct statement in this. So yes, so we have many people with us. Mayank is there, Dr. Anil Soni, yes. I am waiting for the answer. Can anybody tell me what is the correct answer to this? Which is the correct statement as far as the growth of the child is concerned? Okay, so let us analyze each and every option one by one. The birth weight triples by 2 years of age. You know it is not the correct statement. The birth weight, let us assume the birth weight to be 3 kgs. So it would double by 5 months of age and it would triple by 1 year of age. That means around 9 to 10 kgs is the weight which we see at 1 year. So birth weight triples by 1 year of age and not by 2 years of age. In fact, by 2 years of age, if you know, it quadruples. So by 2 years of age, it is supposed to be quadruple. And why quadruple? Because you know at 2 years of age, the weight is around 12 kg. So considering a birth weight of 3 kgs, the birth weight quadruples by 2 years of age. So first statement is the incorrect statement. Yes, now I am getting the correct answers. Shivangi Tiwari has, Dr. Shivangi has answered correctly. Dr. Anil Soni has answered correctly. But okay, so let us first see the other options also. The infant measures 90 centimeters at 1 year of age. No, this is also the incorrect statement, because we know that at birth the length of the child is 50 centimeters, right? That is what we consider at birth, and the child gains around 50% of the birth length in the first year of life. That means 50 and 50% of this, that means 25, that means 75 centimeters at 1 year of age. Right. So 90 centimeters does not happen at 1 year of age. When does it happen? We should know this also. So 90 centimeters, the length of the child becomes at 2 years of age. At 3 years, it becomes 95 centimeters, right? 3 years of age, and it doubles, the birth length doubles by 4 years of age. So at 4 years of age, it will become 100 centimeters, right? So the infant measures 90 centimeter at 1 year of age is again an incorrect statement. Okay. So here the head circumference, the third option. Okay, so somebody's answered, okay, Dr. Shivangi and Dr. Anil, they have answered the option C as the correct answer. I am sorry, that is not the correct answer. So the correct answer would be something else. So first let us analyze the option C. The head circumference becomes equal to the chest circumference by 6 months of age. Of course, this is a wrong option. Please remember, at the time of the birth, the child is born with a large head. Why large head? Common sense should prevail over here, that 70% of the brain growth has already occurred by birth, right? So definitely the head size is going to be more. So at birth, if you see, at birth, the head circumference is more than chest circumference by 3 centimeters. And it becomes equal, head circumference becomes equal to chest circumference by 1 year of age. If you see in the C option, it is given as 6 months of age. That's a wrong option. So head circumference equals the chest circumference at 1 year of age, and beyond 1 year of age, the chest circumference becomes slightly larger than the head circumference. So again, the C option is not correct. So let us come to the D option. For the first 3 months of life, weight gain occurs at a pace of roughly 20 to 40 gram per day. This is the correct answer. So this you should be knowing, that the first 3 months of life, the weight gain is at the rate of 20 to 40 grams per day. And then thereafter, what is the weight gain? Let us see that. So from 3 months to 1 year of age, it is around 400 grams per day. So that you should be knowing. So not per day, this is per month, 400 grams per month. So this is the roughly weight gain in the first year of life, right? So and thereafter till 2 to 7 years of age, if you want to see, then the weight gain is around 2 kg per year. And then 7 years to pubertal growth spurt, the weight gain, the gain in weight is around 3 kg per year. And then of course the pubertal growth spurt happens and it becomes around 6 to 7 kgs per year, right? So the correct answer in this, I hope everybody's got it right. The answer is D, not C, right? So let us move to the next option. Next question over here. A 7-year-old boy presents to pediatrics OPD with chief complaints of rapid onset of puffiness around eyes, pedal edema, cola-colored urine. These complaints came after he recovered from a sore throat 2 weeks back. All of the following statements are true regarding the probable diagnosis except. So electron microscopy shows humps on the subepithelial side of the glomerular basement membrane. 90% of patients have low serum C3 levels which normalize within 8 to 12 weeks. It usually occurs 1 to 4 weeks after an infection with group B beta hemolytic streptococci, and renal function substantially compromised for more than 7 to 10 days warrants a kidney biopsy. So let us analyze each and every statement. I hope we know the diagnosis over here. Yes, we are talking about none else than PSGN. And what is PSGN? Post-streptococcal glomerulonephritis. And we can very well see, you know, it's like so obvious, and I'm sure my friends have got this answer definitely correct. Yes, so humble doctor is joining me in unison saying yes, it is PSGN. So one thing which is very striking is PSGN usually occurs following a sore throat or a pyoderma. We know this, and the organism implicated is group A beta hemolytic streptococci and not group B. Please understand that. So it is group A beta hemolytic streptococci. So straight away, you know, this option is a false option. So we know the answer is C, right? What about the former part of this option? It usually occurs 1 to 4 weeks. So usually it is said occurs 2 weeks following a bout of throat infection and 3 to 4 weeks following a bout of pyoderma. So that you have to remember. I will write it down for you. So 2 weeks following a bout of throat infection with beta hemolytic streptococci and 3 to 4 weeks following a bout of pyoderma, right? And usually seen in the 5 to 12 year age group. We know this. And in this, what happens, the children, they present with oliguria or maybe anuria, total anuria, and may present with edema, and may also present with malignant hypertension and pedal edema, as this child has already present. And not to forget hematuria, which is the presentation is in form of cola colored urine. So cola colored urine is because of the acid, the conversion of hemoglobin into acid hematin because of the acidic pH of the urine, and that is why we get to see cola colored urine. Right. So this is a typical presentation of post-streptococcal glomerulonephritis. And what happens in this is that usually these children, they respond, they just require supportive measures, nothing more to be done, apart from, managing the complications. Of course, if the oliguria azotemia becomes very high, then one has to resort to dialysis, but then there's a catch in that also, which I will just explain in a short while. So usually they respond to supportive measures and they bounce back very nicely. So that is usual history of PSGN. So what is the timeline? Apart from the timeline of resolution of signs and symptoms, what you need to know is the classic investigation which has to be done in this case, and that is the C3 is low over here. Very, very important. Please remember C3 is low. And the why I am telling you this is because the normalization of C3 usually takes place by 8 to 12 weeks, and if the C3 continues to be low beyond 12 weeks, then that is an indication of doing kidney biopsy. So that is the reason why I specifically told you C3 is low. Renal biopsy is usually not indicated, but of course if done in this case, then what do we find? So in this, if we have to just see on light microscopy, we will find enlarged, enlarged bloodless glomeruli. That is the finding on light microscopy. On immunofluorescence, you will find lumpy, bumpy deposits. We know this, also known as starry sky pattern, right? And this is because of the deposition of IgG and C3. So deposits are composed of IgG and C3, we know this. And finally, on electron microscopy, we find humps subepithelial. On the subepithelial side of the membrane, we will find the presence of humps. So this is the classic thing which we see on renal biopsy. Now very importantly, the timeline which you have to remember, because that is what is asked in your exam, that usually what happens is the azotemia, or for that matter anuria or oliguria, whatever the child has presented with, usually subsides by 7 to 10 days. Then a nephrotic range proteinuria, if occurring, usually does not occur, but if it occurs, it can occur. So it usually subsides by 2 weeks. Then hematuria usually subsides by coming 3 to 4 weeks of illness, right? And C3 levels we already discussed, they become normal by beyond after 8 to 12 weeks. So the upper limit is 12 weeks, right? If this timeline is not followed in a child, then these are the indications of doing a kidney biopsy. That means if the azotemia, anuria, oliguria persist for more than 10 days, or C3 levels at 14 weeks I still find low in a child, this would prompt me to order a kidney biopsy. Other than this, there are other indications of doing a kidney biopsy, which just these indications would tell you that probably you are not dealing with a straight simple PSGN, and that is presence of systemic features. If present, what systemic features? If there is associated, let us say, presence of a rash, right, or joint pains or fever. So in this case, yes, I would go for a kidney biopsy. Or if the child presents with the combination of nephritis as well as full-blown nephrotic syndrome, then again I know this, I am not dealing with simple PSGN, right? And if the azotemia is so severe that one has to resort to dialysis, then again this is an indication of going for kidney biopsy. Please understand this. These are the indications where the doing kidney biopsy is essential, because probably we are dealing with something else and just not simple PSGN. Another very important thing from this question point of view is that you will be asked, you will be given a similar kind of history, and then you would be asked, but there would be certain twist in the history. The twist, one of the twist would be the sore throat maybe occurred 3 to 4 days back. And another point in the history would be that the child has had similar episodes in the past. So that means the recurrence of hematuria, this is reference to the presence of hematuria. So if there is recurrence of hematuria in the question mentioned, and the duration between the sore throat and the presence of and the appearance of hematuria is just 3 to 4 days. And of course one more point, so first point, second point, and the third point is presence of loin pain. If these 3 points are additionally given or given in this question, modified in this question, then the diagnosis becomes IgA nephropathy. Always remember this, because it's a very similar kind of question with some tweaks in the history, and they would direct you, they would expect an answer of IgA nephropathy. So that should be very clear. right? Yes, so Dr. Humble has answered correctly, Dr. Anil Soni has answered correctly. So this all tells you that you are dealing with PSGN and it occurs with group A beta hemolytic streptococci and not group B. So that is why this is the correct answer, and rest the options we have already discussed. So now let us move to the third question. A 6-year-old girl is brought to the emergency department with fever, convulsions and increased neck rigidity. On examination, there is pain on the passive knee extension. CSF examination shows reduced glucose, increased lymphocytes, right, and the increased lymphocytes, and then you also have increased proteins very importantly, and there is a formation of cobweb coagulum when CSF is left standing for a while in the test tube in an erect position. What is the most likely diagnosis? A straightforward question. I am sure everybody would have got this right, but let us discuss this also. So bacterial meningitis, is it bacterial meningitis, is it tubercular meningitis, is it viral, or is it fungal meningitis? So what are the pointers in this question? See, every question would have 1 or 2 pointers that would lead you to the answer. Now your job is to go towards those pointers meticulously. So let us look at those pointers. So first of all, you know what they are describing is fever, convulsions and increased neck rigidity, and there is one more sign of meningitis which has been described here, that is pain on the passive knee extension, and this is referred to as Kernick sign, right? So Kernick sign is positive, which just indicates meningitis, right? Meningeal irritation. It is not specific to any type of meningitis. It is just a sign exhibiting meningeal irritation, right? Now CSF examination shows reduced glucose, increased lymphocytes. Important is lymphocytes. So bacterial meningitis is out, right? Increased proteins. So when there are too much increased proteins, how do we know that increased proteins is just bacterial meningitis also has increased proteins, right? So what is one more thing which is pointing towards too much increased proteins, and that is formation of a cobweb coagulum. Please understand, when there is increased fibrinous response in CSF, then we have this formation of cobweb coagulum, which is seen when the CSF is left in a chest tube in the standing position untouched for a while. So there would be formation of a pellicle or a membrane kind of thing which we refer to as cobweb, something the cobweb as made by a spider. So that is what is seen over here. So this is so very typical of, yes, you guessed it right. Dr. Apurva has answered correctly. Dr. Dipanshu, Dr. Anil Soni, everybody is giving me correct. Dr. Shivangi, Dr. Apurva Shri. Yes, this is tubercular meningitis. So we are dealing with tubercular meningitis because you should understand in tubercular meningitis there is intense fibrinous response in response to the tubercular infection of the meninges, and the protein content can go to up till 8 gram per deciliter of CSF. Imagine that much protein, and that is why we get to see such a response. And I hope everybody knows the focus, the initiation of the tubercular meningitis is by the formation of focus in the meninges, and this focus in the meninges has a specific name to it. Can anybody tell me what is the name given to it? The name given to is Richt's focus. Please remember, it is the name given is the Richt's focus. Rich matlab Amir wala. So Richt's focus is the name given to the focus on in the meninges because of the tubercular infection of the meninges, one of the most serious infections seen in childhood. Usually it involves the children who are of lower age, 2 or 3 years of age, and usually children who have some antecedent history of measles infection, because measles would make the child immunocompromised and vulnerable to the attack by tubercular bacilli, and also if the child has PEM and inadequate nutrition. So these are all the predisposing factors which predispose the child to develop tubercular meningitis, right? So in this case, yes, the correct answer is tubercular meningitis over here. Yes, Dr. Shivangi has answered it correctly. Dr. Lizzie B has also joined us. Yes, doctor, it is Richt's focus. Okay, and these are the signs which are elicited in a case of meningitis, which just tells you that yes, there is a meningeal irritation occurring in this child, and that is when on flexing the knee at the hip joint, when you try to extend at the knee joint, it will not go beyond 135 degree, right? It will not go beyond 135 degree. So that means, I'll just write it down correctly. So it will not go beyond 135 degree, and the knee joint cannot be extended, and this is because of the pain in the hamstrings, and this is again because of the irritation of the motor nerve roots that are passing through the inflamed meninges. So that is the reason. Then this is another sign known as the Brudzinski's neck sign. So in Brudzinski's neck sign, the child is made to lie supine, and then if the neck, there's a passive neck flexion occurring. So on passive neck flexion, the knees would also flex. So this is the Brudzinski's neck sign, right? So I guess this is on examination, there's pain on passive knee extension. That would be the description of Kernick's sign was described in the question, right? So this is it about tubercular meningitis, and we should know there are, in children we treat by 12 months of ATT. I hope you know this. There is 2 months of 4-drug ATT, and there is, then this is the intensive phase, and then this is followed by 10 months of 2-drug ATT, in fact 3-drug ATT as I call it. So I'll just write down 10 months of 3-drug ATT is given over here, and this is known as the continuation phase, right? So this is 2HRZE plus 10 HRE, and remember, always remember, in tubercular meningitis we give initial 8 to 12 weeks. In the initial 8 to 12 weeks, we also add on steroids over here. Very, very important, and steroids are life-saving in fact in this condition. So that has to, yes. Okay, so this is all about tubercular meningitis, and this is, I got this picture for you. This is the test tube, if you can see, and this is the CSF, and this is the formation of a cobweb coagulum, and this cobweb coagulum is nothing but suggestive of a very intensified proteinaceous response in the CSF. Tuberculosis basically attacks, the basal cisterns and also causes communicating hydrocephalus. So if you do a neuroimaging in tubercular meningitis, what do we get to see is basal exudates. So basal exudates is pathognomic along with communicating hydrocephalus. Remember, even non-communicating hydrocephalus can occur in tubercular meningitis, but the commoner one is communicating hydrocephalus, that you have to remember, right? Okay, so let us move forward. Let us come to the next question, and the next question is: a mother suspects a developmental delay in her 3-year-old child, so she brings her to a pediatrician. The pediatrician assures her that the child is not lagging in any milestone. Which milestone, in the following options was present in this child, which will assure the pediatrician? So let us see the milestones. So going to the toilet alone, saying songs or poems, telling stories, sharing toys, knowing full name and gender, dressing and undressing himself. So in a 3-year-old child, do you expect the child to go to the toilet alone? No. The answer, this usually comes around 4 years of age. Remember that, right? Do you expect the child to, sing songs, tell you poems, narrate poems, or tell you stories? Again, this comes at 4 years of age. Remember, right? And the child over here is just 3 years old. Why do you expect that he would perform the activities of a 4-year-old, right? Sharing toys, knowing full name and gender. Yes, this is actually comes at 3 years of age. So if the child is doing this, we are very happy that he is corresponding, his activities are corresponding to his chronological age. And dressing and undressing himself, if the answer would have been except buttons, right? If the statement would have been except buttons, then I would have given 3 years over here. But if the statement is only dressing and undressing himself, that means including buttons also, then this comes at 4 years of age. Of course, somewhere in certain books, there are so many books, telling you about the milestones. There is the mashup somewhere it is given 3 years also. But remember, sharing toys, knowing full name and gender, there is no controversy about this kind of milestone. This comes at 3 years of age. In certain books, you will find dressing and undressing himself also at 3 years of age. But then, if it is except buttons, definitely I would have given at 3 years. But if it is just dressing and undressing himself, that means including the manipulation of buttons. The manipulation of buttons, remember, comes at 4 years of age. Remember this, right? So that's why our correct answer over here would be the option C, that is sharing toys, knowing full name and gender. I hope you have understood. This was a tricky question, especially the fourth option, dressing and undressing himself. But when you have a better option, please go for it, because sometimes or the other you will get such tricky questions, right? Okay, so this is how it is, yes. So all have answered correctly. Dr. Humble, Dr. Anil Soni, Dr. Shivangi Tiwari, Dr. Lizzie B, all are giving me correct answer. I am very happy that you have done this correctly. Okay. A newborn is assessed by Apgar score 5 minutes after his birth. He was found to have a heart rate of 50 per minute, grimace in response to catheter guided stimulation of nostrils. The color was pink. On examination, he showed active movements and had a strong cry. Calculate the Apgar score for the infant. See, please remember, whenever you get questions on Apgar score, don't try to mug up the question. Try to mug up the score. It will always help you, right? So I've seen, kids, they tend to mug up the question कि इसका तो answer 6 है, इसका तो answer 8 है. Please ऐसे मत करिए, ठीक है? They can change at any, any of the feature can be changed, and then you will be in trouble. So you should know what score is awarded to each feature in the Apgar score. Very, very important. So the options are 9, 6, 7 and 8. So let us calculate the Apgar score together. Okay, so heart rate of 50 per minute. So this, more than 100 per minute gets you a full 2 score, less than 100 per minute gets you a 1 score, and no pulse exactly gets you a 0 score. So for this, the child gets, let us say, a score of 1, right? Then grimace in response to catheter guided stimulation of this, again we get a score of 1 over here. Then the color was pink, that means the child is pink throughout. This gets a score of 2 over here. And then he showed active movements, that is the respiration, there was no problem with the respiration, and the active movements was the active movements were there. So again he gets a score of 2, and had a strong cry. This shows that there is no problem with the respiration. Again he gets a score of 2. So if you calculate 2, 2 and 2 and then 1 and 1, the answer comes out to be 8, right? So a quick review of what we were actually discussing for people who have just joined us, uninitiated ones. Apgar score, the mnemonic lies in the word Apgar. A stands for appearance, P appears for pulse, G is for grimace in response to the catheter induced stimulation of the nose, then A is for activity and R is for respiration. So this we know, when the child is blue all over, cyanosed all over, we give the score of 0. Only extremities being cyanosed, we give a score of 1. Rest of the body is pink, and the entire body is pink, because here the child was pink, so we gave a score of 2, right? Then pulse, we have already discussed. Grimace, if there is no response, then we know that this is in response to the catheter induced in the nose. Then we know this is a score of 0. If there is grimace, this is a score of 1. And if the child starts actively sneezing, coughing or pulling away when stimulated with the catheter, then this gets a score of 2, right? Of course, yes. So then activity wise, if there is no movement, there is score of 0, some movement is score of 1, and fully actively moving all extremities, as our child in the question was doing, gets a score of 2. And in respiration, no breathing, and then weak or gets a score of 0, weak or irregular or shallow breathing gets a score of 1, and of course a strong cry tells you that this is a score of 2 as far as the breathing is concerned. So our child had an Apgar score of 8. Yes, so everybody is answering it correctly. Dr. Lizzie, Dr. Anil Soni, Dr. Akash Fulzale, very good. Chalo, let us move further. A 7-year-old girl is brought to pediatric emergency with severe pallor. On examination, hepatosplenomegaly was present. On further probing, she was found to have history of multiple blood transfusions. Her blood, very importantly, then her blood sample was sent for investigation, which revealed a hemoglobin of 7.8. MCV of 66 femtoliter and MCHC was found to be normal. A blood smear showed microcytic hypochromic cells. Which of the following is not correct about the diagnosis? So these are the 4 options which are given to us, that this is a case of thalassemia major and requires critical supervision to watch the complications. Splenectomy is recommended in all cases of thalassemia major. The only known for thalassemia is hematopoietic stem cell transplantation, which we know by the name of HSCT. This condition is differentiated from iron deficiency anemia by the Mentzer index, that is less than 13 is seen in thalassemic patients. Okay. So now let us see which is the not correct. So they are asking about not correct. So this is very clear, the given scenario is in concordance with the diagnosis of thalassemia major. Why thal major? Because the child is transfusion dependent. The HB of 7.8 is by virtue of the multiple blood transfusions the child is getting, and this is not in concordance with the nutritional anemia, because nutritional anemia would not require repeated blood transfusions. Plus, so usually the nutritional anemia would come up when the child is started on inadequately complementary feeds, and is when the child when there is this time of introduction of complementary feeds, that is around 6 to 9 months of age, then the child is still continued with milk only, be it breast milk or be it top milk only, and the complementary feeds are not added adequately, and the child lands up with nutritional anemia, because the top milk has inadequate iron, right? So that is it. And the other ages where you get to see nutritional anemia is around the time when the especially the female child, as this case, would start with her menstrual cycles during the adolescent period. So again, this is not the typical age group. So anyways, and the child is requiring repeated blood transfusion. So this is definitely not iron deficiency anemia, right? Of course, this is thalassemia major, this is very clear, and requires critical supervision to watch for complications. What complications? In thal major, because of repeated blood transfusions and also because of increased absorption of the iron from the gut, there is iron overload in the body, and it usually affects many organs. Iron overload would be seen in, let us say, some examples would be thyroid gland, parathyroid gland would be affected. Even the adrenals are not spared, adrenals also would be affected, and you would also get to see iron deposition in liver and in the rest of even in the pancreas, right, and in the rest of the many organs of the body. So this is how the iron overload occurs, and we have to start this child on chelation therapy, otherwise the child would land up with many problems. The organs would not function properly, there is delay in sexual maturation, there is growth failure, so that has to be taken care of. So I guess the first statement is very much correct statement. Now let us come to the third statement straight away. The only known cure for thalassemia is HSCT. Very, very true. Hematopoietic stem cell transplantation is promising in this case, but then remember, HSCT would not be, I'll just come here. So HSCT would not work for us if the child, comes to us with, let us say, portal fibrosis is there, or if the child is having, massive hepatomegaly, or if the child is inadequately chelated. So in these 3 circumstances, please remember, HSCT would not be promising. So that the child has to be, properly managed before going for hematopoietic stem cell transplantation. So that is, of course, that is the cure for it, right? Okay. Then the fourth statement, if we see, this condition is differentiated from iron deficiency anemia by the Mentzer index. So here there is a catch, because since we are discussing thal major, of course here the Mentzer index is more of use in differentiating between, anybody can tell me? Yes, between iron deficiency anemia and thal trait. Remember, a close differential of iron deficiency anemia is thalassemia trait, right? So that would be more, Mentzer index is used in that scenario. And what is Mentzer index? We know this. It is, we see, we take MCV in femtoliters and we divide it by the RBC count in million per cubic millimeter cube, right? So this is what Menser index is all about. And you know, in iron deficiency anemia, there is less of RBCs being produced. The RBC production is compromised. So definitely Menser index is going to be more than 13 in iron deficiency anemia and is going to be less than 13 in thaltrate, because in thaltrate the RBCs are being produced properly, but there's ineffective erythropoiesis, that because of the clumping of the chains, because of the inappropriate production of the globin chains, the RBC longevity is affected, and therefore we call it ineffective erythropoiesis, right? So of course Menser index helps us in distinguishing between iron deficiency anemia and thaltrate and not thal major, remember this. So if we come back, yes, the fourth statement is almost also okay. Coming to the second statement, splenectomy is recommended in all cases of thal major. No, please remember, it is not recommended in all cases of thal major. And why? Let us see this. So splenectomy, if you know, spleen is a very important organ in children with thal major. In fact, it is a storehouse of non-toxic iron, and it you know, it prevents it's kind of a shield coming between the iron and the other organs of the body. So it prevents the deposition of iron in the other organs of the body in the initial part of the disease. So you should not go for splenectomy straight away. The only indication for splenectomy is if there is hypersplenism occurring. So what do you mean by hypersplenism is, how do you detect hypersplenism? This is when constantly your hemoglobin levels are sliding down and the requirement for blood transfusions is on the increasing trend, right? So requirement for blood transfusion is on the increasing trend. And what do you mean by increasing trend? It is that the requirement is around 200 to 250 ml per kg of packed cells in a year. If the requirement is touching this kind of volume, then it is, you are dealing with hypersplenism, then it is better to go for splenectomy, right? But then before going for splenectomy, two things have to be kept in mind. Usually splenectomy is done in a child who is more than 5 years of age, and remember, all the immunizations have to be complete against capsulated organisms. I don't need to tell you, I'm sure you know this, with what all capsulated organisms I'm talking about. So pneumococcus, meningococcus and H influenza B. So the immunizations, the prophylactic immunization should be complete, and the child should be more than 5 years of age and should be having features of hypersplenism. Then only we go for splenectomy. So please remember the B option. Yes, very true, many people have answered correctly. Dr. Debanjana Sarkar, Dr. Shivangi, Dr. Anil Soni, they are giving me the correct answers. The splenectomy is not indicated in all the cases of thalassemia major, and that is why this is a incorrect statement, right? Okay, so let us move forward. Of course, I need to tell you this also, the MCV was low over here. Remember, in this age group, the normal MCV range is somewhere around 75 to 85 femtoliter. Try to remember these normal ranges. Try to remember it, you know, abruptly, one day, 1 hour, at designate an hour that this hour I will remember a normal range. This will really be handy to you in solving questions, right? So MCV was on the lower side. Okay, now let us come to the next question. A child of short stature is being evaluated. Growth hormone levels are shown to be high, but IGF-1 levels are shown to be low. Which of these is the most likely diagnosis in this child? Is this GHRH deficiency, GHRH receptor defect, GH receptor defect, or none of the above? So if you see this question straight away, this gives you the answer. We are dealing with something we all know. This is Laron syndrome. And what is Laron syndrome? This is nothing but another name is growth hormone insensitivity. And why insensitivity? Because we know growth hormone acts through a receptor which goes by the name of IGF-1. And in Laron syndrome, the IGF-1 levels are low. Remember, they are low, they are inadequate, and because of which the growth hormone is not able to exert its action. So the clinical features will mimic any child of growth hormone deficiency. But when you do the investigations, so on investigations, when you go for a growth hormone stimulated test, right? So for detecting the growth hormone levels, and what do we use for growth hormone stimulation? We use clonidine, you know, clonidine can be used, we can use insulin, we can use arginine, you know, and we can use glucagon. Any of these one can be used before measuring the growth hormone levels. We give stimulation by using any of these one, and then we measure the growth hormone levels. So when we measure the growth hormone levels in Laron syndrome, amazingly the growth hormone levels are high, but the child is showing you the features of growth hormone deficiency, maybe doll like faces and micropenis in the male infants or male toddlers. Micropenis would be there. In females you get to see doll like faces, high pitched voices there. So all features of growth hormone deficiency is there, but amazingly the growth hormone levels are high. Then we know that this is not the culprit, is not the growth hormone. The culprit is IGF-1. The levels are low, and that is why it is always recommended that whenever you do a growth hormone stimulation test, always do a IGF-1 level also, otherwise you will be left groping in the dark just in case if the growth hormone stimulation comes out to be growth hormone levels come out to be normal to high, right. So this is here the answer is straight away growth hormone receptor defect, that is IGF-1 receptor. So we are dealing with Laron syndrome. Yes, very good. So everybody knows this. Dr. Anil Soni, great going. You've given me all the 4 options which we use for GH stimulation, right. Okay, so this is it. Yes, the body is unable to utilize growth hormone. Dr. Anil Soni, very true. And Dr. Shivangi is also answered correctly. Dr. Doc has also answered correctly. So I am sorted. I am very happy that at least pediatrics is going good this way. Okay, then let us come to the next question. A newborn infant presented with a history of abdominal distension and a history of not having passed meconium for more than 48 hours after birth. Confirmatory test to diagnose the condition is it a high fiber diet? Is a barium meal, follow through, rectal biopsy or reassurance? See, please remember, at least reassurance would not be there. Why? You should know 99% of term infants, they pass meconium. And see, this is term infants. For preterms, you can still be lax, right? So 99% of the term infants pass meconium within 48 hours. So this is not at all, reassurance would not help over here, because this is a serious condition. The child has not passed meconium for more than 48 hours. Now the important thing is what should come to your mind, right? If you have a condition like this, one surgical and one medical condition should instantly hit you, and that is the either it is Hirschsprung's disease we are dealing with, remember that, right, or we are dealing with something like congenital hypothyroidism, or maybe we are dealing with celiac disease. In all these conditions there is delayed passage of meconium, right? Congenital hypothyroidism, Hirschsprung's disease, or maybe celiac disease, right? So anyways, let us concentrate more on these two. But if you see, look at the scenario given and the options given, definitely we know that congenital hypothyroidism has got nothing to do with the question at least, right? So let us concentrate on Hirschsprung's disease only. Do we go for a high fiber diet? Come on, in a newborn infant, what will a high fiber diet do, right? So this is straight away again striked out, right? Now, of course, you are stuck up between B and C. What are you dealing with? Is it, do you do a barium meal follow through, or you do a rectal biopsy? So coming to Hirschsprung's, you know Hirschsprung's is because of the aganglionosis which is seen, that is there is absence, paucity of the ganglion cells in the wall of the intestinal wall, and this is usually seen just proximal to the anus for some distance. For some distance means usually the aganglionic segment is localized to rectosigmoid region in at least 80 to 90% of the cases, right? And sometimes it may also involve some segment proximal to the sigmoid colon, then we call it long segment disease, and this long segment disease is usually seen in 10 to 15% of the patient, but mainly the most common is the rectosigmoid region. And of course, we also get to see total aganglionosis, remember that, but that is very, very rare, seen in only 5% of the total cases of Hirschsprung's disease. So why does this occur? This occurs because there is the neuroblast migration that was supposed to migrate from the proximal to the distal bowel, that is arrested at some point, and that is why the distal bowel is not innervated properly, if there is absence of the nerves in the distal bowel, what will happen? Just tell me. If there is no ganglionic cells in the distal bowel will fail to relax, will be in perpetual contracted state. There will be no movement of the material or the fecal material in that bowel. The movement, the forward movement, you know, is achieved by peristalsis, and the peristaltic movements are by virtue of the ganglionic cells in the wall of the small intestine, right? So that would not be there, and if that is not there, what happens is the proximal bowel, which is the unaffected bowel, that becomes dilated, you know, with the fecal material, and the distal aganglionic segment is shrunken, and it is in a perpetual hypertonic state and devoid of the fecal material, right? But the fecal material is going on collecting in the proximal segment of the bowel, right? So that is what we see, that is the basic pathophysiology behind the Hirschsprung's disease. Now, how do we make a diagnosis? Of course, there are many ways to make a diagnosis, but the gold standard, always remember, is the rectal suction biopsy. Can we do a barium enema? Of course, we can do a barium enema, in which what we get to see is a proximal dilated bowel, and this is then followed by an abrupt transition where you get to see a transition into a small contracted bowel, right? And that is the distal portion, which is the aganglionic portion. So that is what is seen in the barium enema. But remember, barium enema is not to be done. Barium enema is not to be done in less than 1 month of age, because in less than 1 month of age, sometimes the proximal bowel does not get dilated that much, and then it will not be diagnostic. Okay, then what else can we do? We can do a anorectal manometry, you know, where we place a balloon in the rectum, and then what we see is the response of the internal anal sphincter to the rectal distension because of that balloon. So normally the internal anal sphincter should relax, right? But if it fails to relax, then that is very much suggestive of, in fact, to the extent of 90% surety, we can say we are dealing with Hirschsprung's disease. But remember, these two things which I have told you, anorectal manometry or barium enema, these are all aid to the diagnosis. They are not considered to be the gold standard. The gold standard is always rectal biopsy. And what do we see on rectal biopsy is the absence of ganglionic cells, that we already know, and there is, you know, abundance of nerve bundles is there, right, and which stain with abundance of acetylcholinesterase. So even this is in very high quantity in that biopsy specimen. So we can use certain stains to detect the presence of acetylcholinesterase, and that will tell you that yes, we are dealing with Hirschsprung's disease, right? Okay. So Dr. Anil Soni has told me that ma'am, less than 1 month में barium meal नहीं होगा. Yes, that's what I have just told you, नहीं करेंगे in less than 1 month, right? So Shivangi Tiwari, Dr. Anil Soni, yes, doctor, they have all answered correctly. The correct answer would be rectal, doing a rectal biopsy over here, right? So rectal biopsy is the correct answer over here. Okay, then so that is the confirmatory test. Let us move on to the next question. A 1-month-old female neonate is brought by her mother for evaluation of hypotonia. The baby was born at term to an elderly gravid mother. She has dysmorphic facies, flattened nasal bridge, upward slanting palpebral fissures, epicanthal folds, short narrow palate with small teeth, furrowed and large protruding tongue, small and dysplastic ears, brachycephaly, flattened occiput. She has short broad hands with a transverse palmar crease. What is the most probable syndromic diagnosis? I am sure you must be knowing this is a straight question served to you on a platter. Yes, this is straight away. I will not even show you the options. Yes, let me show you the options. The answer is Down syndrome. All features of Down syndrome, I am sure you must have, learned by now. So these are very typical of Down syndrome. Had it been Edward, we would have mentioned rocker bottom feet, remember that, and we would have mentioned something like microcephaly, right? So these are, and then of course the most common congenital heart defect, that is VSD, that is seen in Edward syndrome. And Edward syndrome is because of the trisomy 18. Yes, E for 18, remember that ways. E is for 18 and E is for Edward syndrome. We know this, right? Then Patau syndrome is because of trisomy 13. You should know this. Trisomy 13 is over here, and here you get to see cleft lip and cleft palate very importantly, and we also get to see again microcephaly in this case, and again the commonest heart disease over here is VSD, but we don't get to see rocker bottom feet. In fact, here we get to see overlapping fingers, right? In the last, I think, exam of your FMGE, this mock test, you had Patau syndrome, and we had discussed Patau syndrome in detail over there, right? So overlapping fingers would be seen. Turner syndrome, there are many features of Turner syndrome. We know it's seen in a female, where you get to see low posterior hairline, webbing of the neck would be there, shield type chest would be there, and shield type chest, and widely spaced nipples would be there. There would be higher, the wide carrying angle of the in the elbows would be seen, and there would be streak ovaries, and the child would present to you with short stature, not to mention primary amenorrhea. In fact, it's a dictum, any female presenting to you with short stature with primary amenorrhea, your first suspicion should be Turner syndrome. Start investigating for Turner's, right? So you should know this kind of, if symptoms come in your question, then you will be able to do Turner syndrome. Yes. So this is trisomy 21, very clear. Now let me tell you what is the commonest congenital heart defect. Can anybody tell me in Down syndrome? I am leaving it to the house. I will come back again to this question. So let us move forward to with the other question. But yes, the question for you is, tell me the most common congenital heart defect seen in Down syndrome. Okay. So now let us move to the next question. But before that, just see this is how the child would look like. The upward slanting palpebral fissure, you can see that. Flat facial profile, you can see, and there's a single palmar crease you can see, and this is known as the sandal gap. So this is very much typical. If you have these kind of pictures and they ask you guess the diagnosis, I'm sure you'll be able to do it, right? Okay. Yes, Shivangi Tiwari is telling me, Dr. Shivangi is telling me 45XO, yes, that is seen in Turner syndrome. Okay. Now let us, so my question is still there. I am waiting for the answer from your side. What is the most common congenital heart defect seen in Down syndrome? Let us move to the other questions. That is, a 4-year-old male child presented to ER with left focal onset seizures. On examination, he had frontal bossing and wrist widening and was in the post-ictal phase. He is otherwise developmentally normal, very importantly, with no past or family history of seizures. His ECG shows a QOTC of 0.49. This is suggestive of which electrolyte abnormality. So if you have seen the question, you will come to know that they have mentioned in the question certain features of rickets, and we all know rickets is a case where there is defective mineralization of the growing bone. And what is the two causes? The two main causes of rickets is either there is deficiency of calcium or there is deficiency of vitamin D. Remember, in our country usually this is not the case. This is the case. Deficiency of vitamin D is the main feature, and because of deficiency of vitamin D, you know, even the calcium is not absorbed. So ultimately we land up with deficiency of calcium in this case, but this is compensated by the over secretion of PTH, parathyroid hormone, which comes into play and tries to leach out calcium from the bones, and because of which in rickets, in fact in the early stages of rickets, what we get to see is the normal kind of calcium levels. Remember, this should not deceive you that normal calcium levels cannot occur. In fact, normal calcium levels is seen very very prominently in rickets in the initial stages of the disease. But of course, in the later stages of disease, that means the disease is of long standing, not being corrected adequately or not being detected by anyone, so no treatment has been given to this child, then definitely in the later stages the calcium levels would fall, and when the calcium levels fall, then you land up with these kind of seizures which this child had, right? So this child had seizures, and these were most likely hypocalcemic seizures in association with features of rickets like frontal bossing, wrist widening. You can have double malleoli, you can have Harrison sulcus, you can have a rachitic rosary also. So these are the features of rickets with seizures. You will always suspect hypocalcemia. Yes, another very important feature of hypocalcemia is QOTC, prolongation of a QOTC. So what is QOTC? You should know what is first QOT. So QOT is the QT interval which is modified. How it is, QT interval is from the start of the Q wave to the end of the T wave, right? You agree with me. What is QOT? O is for the onset of T wave. So here in QOT interval, we do not take the T wave into consideration. We just take the interval from the start of the Q wave to the starting of the T wave, because this is the time, this is the part, if you chart, if you just see the graph of depolarization of the muscle superimposed with the ECG. So this is the part where the calcium would work. So therefore, to make it more specific for calcium problems, we measure the QOT interval. I repeat again, it is from the onset of the Q wave to the onset of T wave, right? And what do you mean by C? So if I write C, that means it is corrected for heart rate. And how do you correct it for heart rate is, you divide the QOT interval with under root of RR interval. Remember that, right? Yes. So this is known as the QOTC, and normally for QOTC, if more than 0.20 seconds, in certain books 0.22 seconds also used. So any QOTC which is more than 0.20 to 0.22 seconds, that tells you that this is a prolongation of QOTC interval, and this is suggestive of hypocalcemia, right? Yes, so very true, everybody's answered me correctly. Yes, so okay, I've got the answer to my question. Good going, everyone. So Doc has answered. I get it. It is not Cushing effect. You have probably in hurry you wrote it Cushing effect. It is endocardial cushion defect. Yes, that endocardial cushion defect is the most common congenital heart disease seen in a child with Down syndrome. So Dr. Akash also gave me the correct answer. Dr. Shivangi, Doc, then okay, so everybody is given me the correct answer for endocardial for the question posed by me. Now the question which we were discussing, question 10, yes, the correct answer is C. That is, the answer is hypocalcemia in this case, right? So let us move on to the other question, and that is, a 1-month-old child presented to the emergency department with fast breathing. Child was feeling well. Yes, as per the parents, as per the ARI control program, how will you classify this pneumonia? Is it no pneumonia, some pneumonia, severe pneumonia, or very severe pneumonia? Now, you know, there's a catch, again the catch in this question. If you, I know, I mean, all of you are very intelligent, and you should know how to, you know, identify the catch in the question. So definitely there is nothing like some pneumonia. There is no entity as some pneumonia. There is an entity like some dehydration, but there is no entity as some pneumonia. Remember this. Again, remember, there is no entity as very severe pneumonia. Either it is severe pneumonia, or if you have, you know, read it carefully, it is very severe disease. It is not very severe pneumonia. So at least 2 of your options are out. The child is not in this. Now if you see the other 2 options, very simple. The child is having fast breathing, right? If the child is having fast breathing, definitely it cannot be no pneumonia. Straight away the answer becomes severe pneumonia, right? So this is a very easy way of doing the question, but of course if you see, if you do it systematically, methodically, if you want to do this question, then you should know this classification. The ARI control program is somewhat different for children who are less than 2 months of age and who are between 2 months to 5 years of age. For less than 2 months, they have just given for the pneumonia, either it is severe pneumonia or very severe disease, and in this they have put everything: fast breathing, chest indrawing, and the general danger signs like, you know, inability to feed, convulsions, lethargy. Everything is put into one this thing, and it has been labeled as very severe disease or severe pneumonia. The other category over here is local bacterial infection, where you get to see either the umbilical stump sepsis, or either we are dealing with the umbilical stump sepsis, or we are dealing with, let us say, the pustules all over the body, right? So that comes in the local bacterial infection. And then severe disease or local infection, unlikely, that means it is not there, right? So this kind of classification goes for the children less than 2 months. In children between 2 months to 5 years, yes, they have given very severe disease. As I told you, there is nothing as very severe pneumonia. Please keep that in mind. And or severe pneumonia, where you have the general danger signs also present along with fast breathing. and chest indrawing. So if you have fast breathing or chest indrawing, then that comes in pneumonia. And if you have the general danger signs along with it, what are the general danger signs? Inability to feed, convulsions, lethargy, stridor in a calm child. All these 4 features are the general danger signs. If they are present along with fast breathing or chest indrawing, then the child lands up in this category, right? So this child, if you saw, was in the 1-month-old category, so it will be classified with this classification, and this will be severe pneumonia, right? Fast breathing, then severe pneumonia. Yes, and I hope you know the cutoff. So less than 2 months of age, the cutoff is 60 per minute. The breathing rate, if it is more than 60 per minute, we call it tachypnea. For 2 to 12 months, the cutoff is 50 per minute. Yes, then it will be called as tachypnea. And for children who are from 12 months to say 60 months of age, that means 5 years of age, the cutoff is 40 per minute. So you should also remember these cutoffs for how to classify whether the breathing is fast or not, right? Okay, yes, chest indrawing. So Dr. Anil Soni is answering me. So yes, the correct answer over here is severe pneumonia. Okay, now let us move forward. A group of students in a school were evaluated for rheumatic fever. Which of the following is not the major criteria as per revised Jones criteria used for diagnosis of rheumatic fever in the school where most of the students are in low risk population? Okay, so when we are talking, so let us see the options: chorea, erythema marginatum, polyarthralgia, and subclinical carditis. So we know. Okay, so Dr. Ajay Thorat is asking me how to treat severe pneumonia. Yes, in severe pneumonia, you have to give the first dose of ampicillin, parenteral antibiotics in form of ampicillin, gentamicin, or maybe oral amoxicillin and gentamicin. Oral would not be a very nice idea to give, especially when the child is having fast breathing or severe pneumonia, right? So usually you give first dose of parenteral antibiotics and you refer the child to the hospital or the tertiary care center or any health center, right? So that is how it has to be treated. I hope you got my you got the answer, right? Okay, then let us come to the next question we were discussing. So the major criteria, if you know the Duckett-Jones criteria, the major criteria were the chorea, Sydney-Ham's chorea, if I write it down like this, carditis, yes, and we have arthritis, and we know the features of arthritis. It is non-deforming, migratory, polyarthritis. We have the subcutaneous nodules, which are usually seen on the extensor surfaces and which are non-tender, right? And they usually are associated with the underlying carditis. I hope you know this information of subcutaneous nodules. And of course, we have the erythema marginatum, which we never see in our country population because of the usual dark color of our skin, right? So anyways, these are the 5 major criteria what we see in a child in acute rheumatic fever, which is used for the diagnosis of acute rheumatic fever. So these are only the major criteria. Of course, we have the minor criteria also. I hope everybody knows the minor criteria. It is fever, arthralgia, right? And there is elevation of acute phase reactants. And what is acute phase reactants if we see? So ESR would be increased and CRP would be increased. Now how do we tackle this question in particular? So when this is a low risk population, in the low risk population we would follow the classical Duckett-Jones criteria only. That means the 5 major criteria like this and the 2 minor criteria like this. If the child is coming from moderate to high risk population, then definitely there is change in these criteria. What is the change? In moderate to high risk, in the major criteria, remember in the major criteria there is addition, there is a 6th major criteria, and that is polyarthralgia. Remember this, polyarthralgia is also now considered as one of the major criteria, especially when you are trying to diagnose acute rheumatic fever in a child coming from a high risk population. And high risk population is where the prevalence and the incidence of the disease is more, right? So polyarthralgia would be there in the major criteria, and in the minor criteria there would be monoarthralgia. Even monoarthralgia is there, that would be considered as a positive minor criteria. So that is the difference. Another difference is the cutoff of the acute phase reactants, right? So CRP, ESR in the population where you have the low risk population, so there the cutoff for ESR is more than 60 mm per hour, right, and CRP is more than 3 milligram per deciliter. And if a child who's coming from the moderate to high risk population, there the cutoff for ESR is lowered. It is more than 30 mm per hour, remember this, and the CRP is same 3 milligram per deciliter. So, can you did you understand this, that in fact if a child is coming from moderate to high risk population, then we have actually lowered the threshold of diagnosing acute rheumatic fever, right. So in this case, even arthralgia if present, polyarthralgia becomes the major criteria, a monoarthralgia becomes the minor criteria, right. While in the child coming from low risk population, the same thing, the usual Duckett-Jones criteria, they continue. And as far as the acute phase reactants, you can see that we have decreased the threshold in the child coming, especially in case of ESR, in a child coming from moderate to high risk population, right. So with this kind of scenario, since the child is from the low risk population, definitely yes, our answer is going to be C. Polyarthralgia will not be included in the major criteria. It will be only included if the question mentioned moderate to high risk population, right. So I hope you have understood this. Yes, so everybody is giving me the correct answer. Manish Raj has told me, Dr. Manish has told me C, Dr. Anil Soni also C, Shivangi also C, Somi Ali has told me A. No beta, A will not be the correct answer. Sydenham scoria is very much a major criteria for diagnosis of acute rheumatic fever, right. Okay, so ESR, no, Dr. Anil Soni, ESR more than 60, yes, that is for the children coming from the low risk population, and ESR more than 30, it is not 40, it is ESR more than 30 in children coming from moderate to high risk population, right. Okay. Clear. Now let us come to the next question. A newborn after having undergone the initial steps of resuscitation did not show any improvement even after applying positive pressure ventilation. There was no increase in heart rate. What should be the next line of management? Okay, so these are the options given. Now again, as I always tell you, there's a catch given in the question, and an intelligent student would find the catch and solve the question correctly. So what is the catch given in the question? So majority of you would fall for, hopefully would not fall for, but yes, some of you would fall for the first option, start chest compression, because the child is not responding to positive pressure ventilation. But dear, we all know for starting chest compression, the heart rate should be less than 60 per minute, very importantly. In fact, the correct statement is something else, but very importantly, at least the heart rate should be less than 60 per minute. Have they mentioned in the question that the heart rate is less than 60? No, they have not mentioned. So don't fall in this trap. So we will not go for start chest compressions, right? Okay, so what do we do? So when this is the okay, so first let me tell you this is the correct protocol, the complete protocol of neonatal resuscitation, if you can see, right. So in this step, if you can see, this step is the initial steps, because it is mentioned in the question. That's why I wanted to tell you the initial steps consist of taking, receiving the child in a pre-warmed towel, right, and keeping the child under the radiant warmer, drying the child, and positioning his mouth open and the neck to be extended so that suction can be done if required, if there are too many secretions. Mandatory suction is not required. So that is what it consists of initial steps, right. Okay. So that is what consists of initial steps. Now after that, if still while performing the initial steps, the ongoing evaluation continues. If the heart rate is less than 100, we start with positive pressure ventilation. So PPV has to be started, or if the child is apneic or gasping, PPV, positive pressure ventilation with bag and mask, has to be started. Now when we have started bag and mask, that is what the question was, that after bag and mask there is no improvement in heart rate. What do we do? So remember, we have to see for the chest rise, are we doing the bag and mask properly or not? So the next step over here, if you can see, the heart rate is not improving, we are over here. What do we do? So if this is not improving, then we have to ensure adequate ventilation, and adequate ventilation means to take the ventilatory corrective steps. So what ventilatory corrective steps actually come in a mnemonic, which we write like this, MR SOPA, and there is importance of this full stop which have dot which I have placed in between. So MR SOPA means these are the ventilation corrective steps which we are supposed to take if the chest is not rising by a positive pressure ventilation. So common sense, if the chest is not rising, that means you are not giving the breaths effectively. How will the heart rate improve, right? So what is MR SOPA if you want to see? So MR SOPA, M starts for mask adjustment, R goes for reposition of the head and neck, then there was a full stop. If you remember, I had put a dot over there. So that means then give 5 breaths over there and see whether the chest rise is now occurring or not. If the chest rise is not occurring, then you proceed to the next step, that is S. And what is S is go suction the mouth and nose. Remember, mouth has to be suctioned before the nose. This is again asked in your exam. So suction the mouth and nose using a bulb syringe or a suction catheter, right? Okay, then open the mouth, and O is for opening the mouth by inserting the finger so that your breaths can be effectively delivered to the child. And then again there was a dot. So that means dot means pause now and now give 5 breaths again and see whether the chest rise is occurring. If still not occurring, then you go for P. P stands for pressure increase, and the pressure increase, the maximum pressure that can be delivered to a term infant is 40 millimeter of water, and for a preterm is 30 millimeter of water, right? So that is the maximum, and the increments have to be done in 5 to 10 centimeter of water. Increments have to be done, not straight away 40 millimeter of water. So that is important. And then again, if you see, I had put in a full stop. So that means that full stop is indicative of again giving 5 breaths and assessing the chest movement. Again, if no chest movement, then you go for A, that is alternative airway, that is either you intubate the child or you go for laryngeal mask airway. So these are the ventilatory corrective steps. Now the correct statement of starting chest before starting chest compression is, indication of starting chest compression is, if after 30 seconds of MR SOPA, still, that means if after a visible 30 seconds of visible chest rise, doing ventilation with a visible chest rise, and 30 seconds have passed and the heart rate is less than 60 per minute, then you start chest compression, very importantly. So there was a catch in this question itself, that would have taken you to the correct answer, and the catch was that there was no heart rate given, and that is why they wanted you to go for the second option, that is apply ventilation corrective steps, which I have already told you in form of MR dot again, so then dot again, then P, and then so MR SOPA is the corrective steps, right? So I hope you got it, right? Okay, and whenever we start chest compressions, yes, we have to usually intubate the child, because the chest compressions delivery becomes more easy. It is less cumbersome if you are doing with bag, if you are doing with endotracheal intubation. So along with the chest compression, usually we resort to endotracheal intubation. Very correctly pointed out by Dr. Anil Soni. Yes, so correct answer is B, that is Shivangi Tiwari. Dr. Shivangi has given me the correct answer. Okay, now let us come to the next question. And the next question is, a child was kept on regular follow-up for assessment of nutrition status via measurement of mid-upper arm circumference. Below is the image of the instrument used for the same, and the child's reading on the tape is shown below. What is the correct interpretation of the same, right? So these are the 4 statements given, and if you can see, the child is somewhere over here, and this refers to a mid-upper arm circumference of 11.5 centimeter to 12.5 centimeters, right? So this is definitely not suggestive of SAM, severe acute malnutrition, right? So if you see the first statement, the child is a case of severe acute malnutrition and needs immediate care. No, no, no. If you see what are the criteria for SAM, I hope everybody remembers the criteria for SAM. They are weight for height is less than -3 standard deviation. We know this. MUAC, mid upper arm circumference, is less than 11.5 centimeters. We know this also. And of course, presence of pedal edema. Presence of any of these one sign, if at all present in a child, that indicates severe acute malnutrition. Definitely this child is not a case of severe acute malnutrition, because his upper arm circumference is somewhere between 11.5 to 12.5 centimeters as indicated by this diagram. And we all know what are we looking at. This is known as Charcot's tape. This can straight away come as a question for you. So this is Charcot's tape, right? So Dr. Shivangi Timari has written correctly. Yes, this is Shakir's tape. Yes. So Dr. Anil Soni, this is not Shaker's tape. This is Shakir's tape, right? I'm sure you must have written it, by mistake. You know it. It is Shakir's tape. So the child falls under the borderline category and should be given proper nutrition to build up growth. Yes, this seems to be a correct statement. The child is properly nourished as per age and no interventions required. Again, see, there was a catch in this question, and the intelligent one would have caught it, and that is, if the child is properly nourished, why would he fall in the yellow zone? He would have fallen in the green zone. Green is more a color used for everything normal, right? So definitely he is not properly nourished because his MUAC is still at the lower level. So the correct option over here would be the B. Yes, and very correctly given by, yes, Dr. Anil Soni, I gave it to you, mistype ho gaya tha, yes. So very correctly given by everyone, Dr. Shivangi, Dr. Anil Soni, Dr. Somi Ali, yes, they are giving me the correct answer. Dr. Future Doctor 417 has also given me the correct answer, that is the B option. Now coming to the last option, last question, and that is, which of the following statement is false about congenital toxoplasmosis? So before we go on to this, the options reading, let us now discuss something about congenital toxoplasmosis. Congenital toxoplasmosis is intrauterine infection, and usually the maternal infection, that is responsible for the infection to the fetus, and the infective stages in congenital toxoplasmosis are basically of three types. There are, tachyzoids are there. We know this, tachyzoids are responsible for the acute infection. Then we also have the tissue cyst, which are responsible for the latent infection, and we also have the third this thing, that is the oocyst. So I will not go into the microbiology in detail. I'm sure that has been tackled by my microbiology colleague in a very efficient manner. So now let me just move ahead with the clinical scenario. So usually the pregnant woman would be infected by eating raw or uncooked meat, raw and grounded meat usually, and dirty vegetables and contaminated water. So these are the ways by which the pregnant woman gets infected, and this leads to placental viremia, and this viremia spills over into the fetal circulation. Now please remember, it's a rule for every IU infection that the rule for every IU infection is that the transmission to the fetus definitely increases with the increasing the risk of transmission increases with the advancing gestation. That is the rule, right? But the important part over here is that the fetal risk is actually not there with the advancing gestation. The risk to the fetus will be more if the transmission occurs in the earlier gestation. That means especially in the first trimester, and the reason, we all know this reason, and the reason is that in the first trimester there is rapid organogenesis taking place, and at that time any insult would prove doom to the child, to the developing fetus, would be bad for the developing fetus. So the fetal risk or the symptoms in the fetus would be more in the newborn period if the fetus contracted the disease in the first trimester and not in the last trimester. And probably this is the nature's way of shielding the fetus, that the risk of transmission is actually less in the first trimester, and it increases as we go with the advancing gestational age, right? Okay, so what is the risk? If we see the first statement, in fact the first half of the statement, this is actually correct, that the risk of transmission is directly proportional to the advancing pregnancy. If you just see, in less than 13 weeks, the risk of transmission is just 6%, and in around 26 weeks the risk of transmission increases to 26%, and around 36 weeks the risk of transmission increases to good 72%. In fact, it is not 26, it is 40% over here. So 6%, 40, 72%, you can see they are increasing. You don't have to remember these percentages, but this is just to tell you that the risk of transmission definitely increases with the advancing gestation. In fact, around term, that is beyond 37 weeks, the risk of transmission comes to a whopping 90%, right? So this definitely increases with the increasing gestational age. But what about the fetal severity? That is more if the transmission occurs in the first trimester. So if the transmission occurs in less than 13 weeks, then 61% of the fetuses will be symptomatic. Imagine, as compared to if the transmission occurred around 36 weeks, then only 9% will be symptomatic. So you can understand that with advancing gestation, the risk to the fetus decreases, but the risk of transmission increases. And this is a rule with every IU infection, right? Okay, then so this is the first of, obviously the first is false. Then what about the symptoms? You should know that in toxoplasmosis, basically we have four kinds of presentation in congenital toxoplasmosis. The first presentation, you will be surprised to know, is asymptomatic. You will be know that majority of the babies, neonates, which are born to a mother who have been infected with toxoplasmosis during her pregnancy, they are 80 to 90% of these neonates, they are asymptomatic, right? But yes, there's a catch over here. We do not leave these asymptomatic alone. We have to treat the infection in these asymptomatic children also. Please remember this, right? Then the second kind of presentation would be where the newborn would be symptomatic and the symptoms would pertain to any other IU infection. So we get to see hepatosplenomegaly, we get to see lymphadenopathy, we also get to see, diarrhea can be the presentation, pneumonitis can be the presentation, thrombocytopenia would be there, and because of thrombocytopenia the child would land up with petechiae. All these kind of presentation can be there. Apart from this, there can be prolongation of jaundice in these children. And apart from this, in toxoplasmosis per se, so these would be seen with any other IU infection also. But with toxoplasmosis, you also have CNS manifestation. So CNS manifestation would be in form of seizures. And why seizures? Because you get to see diffuse cerebral calcification. Very, very important. Diffuse cerebral calcification is seen, and you can also get to see meningoencephalitis. These children are also at risk for developing hydrocephalus. Remember this, right? And they can also, later on be present with developmental delay and mental retardation. So all these kind of features can be seen pertaining to CNS, and the most dreaded complication is the chorioretinitis. This you are not supposed to forget. Chorioretinitis is again a very important and most common sequelae seen to toxoplasmosis. For that matter, if the child is left asymptomatic. So that I'll come in the fourth presentation. So the third kind of presentation is a delayed kind of presentation, and delayed means up till 3 months, the child might not be symptomatic, and this is usually seen when the child delivered is a preterm. So preterm may come up with all the symptoms which I just mentioned by 3 months of age, right? So that is the third kind of presentation. The fourth kind of presentation is what I just left in middle deliberately, and that is if these children, the asymptomatic, are just left as such without treatment, then any time between infancy to adolescence, these children will present to you with the dreaded complication of chorioretinitis. So that you can call, that can be called as complication, that can be called as sequelae, whatever you want to call it. It is how these children present to you. So these are the four kind of presentation what we see in congenital toxoplasmosis. Now how do we make a diagnosis? So we have two major ways to make a diagnosis. First is the serology. In serology we have IgG, we have IgA, and we have IgM. Remember, IgG, if elevated at 12 months of age, definitely this tells you that this is a case of congenital toxoplasmosis, because if it is passively acquired IgG, that would definitely come down or disappear from the infant circulation by 1 year of age. But then you would not wait till 1 year to make a diagnosis. Of course, you want an early diagnosis. So for early diagnosis, you resort to IgA and IgM estimation. So usually by 10th day, day 10 of life, they are elevated, and they tell you that yes, this child is a case of congenital toxoplasmosis. Remember, the IgG based test is known as Sabine-Feldman test, we know this, and IgM based test is the ISAGA test, we know this, right? Then another way of making a diagnosis is doing a PCR. So PCR is done for urine, can be done on urine, can be done on CSF, and of course can be done on blood. In fact, if you combine PCR on any of, especially the CSF PCR, along with IgM or IgA estimation, the sensitivity and specificity touches 90%. So this is how you make a diagnosis, right? Now next is how do you treat these children? So for treatment, the treatment is, and as mentioned in one of the options, yes, you have to give pyrimethamine with sulfadiazine with folinic acid, and for good 1 year, till 1 year you will treat the child. Yes, if the child is asymptomatic, very importantly, asymptomatic children they are also to be treated, very importantly, that has to be kept in mind. Otherwise, they would land up with chororetinitis at any time till adolescent age, right? And for asymptomatic children, this duration can be decreased to 3 months. So for 3 months also, if you give the combination of pyrimethamine plus sulfadiazine plus folinic acid, this is good enough in case of treating the asymptomatic children, right? And corticosteroids are added if the CSF protein is of higher value, which is touching 1 gram per deciliter, that indicates the CSF involvement. So then you can add corticosteroids in the treatment regimen. But remember, corticosteroids are usually added after the initial 3 to 4 days of starting treatment, not in the first 3-4 days. So first 3-4 days you don't give corticosteroids, you add it after 3-4 days of starting treatment. So that should be kept in mind, right? Okay, so very clearly, so the answer over here, let us come back. Yes, the transmission, if you see the other options, yes, the triad in toxoplasmosis is the CHC triad, as I call it. For children, you are reading PSM, so CHC stands for Community Health Center, but for us, pediatrician, it stands for chororetinitis, hydrocephalus, and of course, the diffuse intracerebral calcification. So this is CHC mnemonic for you in case of, this is a typical triad which we see in toxoplasmosis. Pregnant women are advised to wash fruits and eat, carefully because of this. In fact, having 3 kittens, imagine, is also a risk factor during pregnancy for contracting toxoplasmosis, because we know cat is the only definitive host. Man and the other warm-blooded mammals, they are the intermediate host, but for definitive host, it is the only cat. So having 3 kittens in your home is also a risk factor for getting toxoplasmosis, apart from eating uncooked or raw meat, right? Then treatment includes, that we have already discussed, right? So the correct answer over here is A. I hope everybody enjoyed watching this discussion. Study hard, as I always tell you, keep MCQing. You are almost there. There are hardly 17 days left to your countdown. I know you will rock it, you will ace it properly, and then good luck, all the best, keep MCQing. Thank you.
Hello students, so now we'll be starting with the radiology questions of today's mock test. So the first question is: a 45-year-old male presents to the emergency department with sudden onset severe right-sided chest pain and difficulty in breathing. So we are dealing with the acute chest pain with dyspnea. On physical examination, decreased breath sounds, hyperresonance. So it tells you that there is air in the pleural cavity are noted in the right side of the chest. So there is air in the right hemithorax. Now it can either be in the lung, either in the lung or in the pleural cavity. Chest x-rays performed as shown below. What is the most likely diagnosis? So students, this chest x-ray is a spotter. I'm sure it has been asked in your final prof viva as well. Now whenever you see an air fluid level in the chest x-ray with a hyperlucent lung, so you have to mark the answer as hydropneumothorax. Okay, let's just further dissect this down. So here in the right hemithorax, what you can see is that there are no bronchovascular markings that you can see. On the contralateral side, on the left side, you see these fine bronchovascular markings. So in the right pleural cavity, we have pneumothorax, and since there is air fluid level, the answer is hydropneumothorax. Pleural effusion will not have air fluid level. A right giant bulla, if it's present in the lung, such as in cases of emphysema, also will not have an air fluid level. Pneumothorax also won't have an air fluid level. It will have air through and through. Now, moving on to the second question. 52-year-old woman visits her physician for routine mammogram. She has no significant family history of breast cancer but wants to ensure her breast health. Which of the following is not a malignant feature in mammography? So speculations, do they suggest malignancy? Yes, they are BIRADS 5. Okay, they are highly suspicious of malignancy. Microcalcification, yes. Linear, branching, and pleomorphic microcalcification are BIRADS 5 lesions. Irregular mass, does it predict malignancy? Does it suggest malignancy? Yes, it is also a malignant feature. Macrocalcifications. Remember, macrocalcifications are benign findings in mammogram. So answer here is a macrocalcification. Moving on to the next question, which of the following is incorrectly matched? So what is A? A is the radial head. A is the radial head. What is B? B is the medial epicondyle. Medial epicondyle. What is E? E is the olecranon process. Olecranon process. And what is C? C is the coronoid process of ulna. Coronoid process of ulna. So what is D? Now D is the trochlear notch. D is the trochlear notch. So is A? A is the radial head? Yes, A is the radial head. B is the medial epicondyle? Yes. Is C the trochlear notch? No, D is the trochlear notch. And E is the olecranon ossification center? Yes, E is the olecranon ossification center. Now we move on to the next question. Which of the following statements is true about the contrast agent given below? Now students, let's zoom on to this image. What is written? So it's written iohexol. Iohexol. Now what type of a contrast agent is it? It's first used in CT. So it is a CT contrast agent. CT contrast agent. It is given intravenously. Okay. It's water soluble because any contrast which is given IV has to be water soluble, right? It is water soluble. And what class of CT contrast agent does it belong to? It belongs to non-ionic monomer. Non-ionic monomer. And what kind of osmolality do they have? They are low osmolar contrast agent. They are low osmolar contrast agents. Okay. Other examples apart from iohexol. So one is iohexol. Another is iopamidol. Iopamidol. Another is iobitrol. Iobitrol. Another is iopromide. Okay, so these are examples of non-ionic monomers, which are type of CT contrast agents. So let's go with each of the options one by one. Is it a type of water insoluble contrast media? No, it is a water soluble. So the question is asking us a true statement. Option B, most preferred contrast for vascular administration. Yes, it is the most preferred contrast for vascular administration in CT. This is an example of high osmolar contrast media. No, it is an example of low osmolar contrast media. And finally, is it commonly used for MRI? No, it is used for CT. So the correct option here is option number B. Now we move on to the next question. A 45-year-old male presents to the urology clinic with complaints of persistent flank pain on the right side, intermittent fever and weight loss over the past few months. He has a history of pulmonary TB. So there is past history of pulmonary TB which has been successfully treated. Now the lab investigation suggests raised ESR and CRP, and urine analysis shows sterile pyuria. Now this is a buzzword that is given in the question, and whenever you see the buzzword sterile pyuria, what you have to consider? You have to consider genitourinary TB. So the question is basically asking us what are the various signs of genitourinary TB. So first is cement kidney. Is it seen in TB? Yes. So the question is asking, so the following will not be seen. Will not be seen. So will cement kidney be seen? Yes, it is also known as putty kidney, and it will be seen in cases of genitourinary TB. Thimble bladder, is it seen in GUTB? Yes. Moth-eaten appearance of calyx? Yes. Pear-shaped urinary bladder. Now this is not seen in GUTB. It is seen in extrinsic bladder compression. Extrinsic bladder compression. For example, a pelvic hematoma or a pelvic mass. Okay, so pear-shaped bladder is the correct option here. It is not a sign of genitourinary TB. Now we move on to the next question. A 48-year-old alcoholic male presents to the casualty with upper abdomen pain. So it's an acute upper abdomen radiating to the back. So it suggests it's a type of acute pancreatic pain. So his serum lipase and amylase were raised, and likely a diagnosis of acute pancreatitis was made. Now, a CT was done to rule out any complications. So, when is the CT actually done in cases of acute pancreatitis? Day 5 to day 7. And CT showed a bulky pancreas with heterogeneous fluid collection. So, what is the likely diagnosis? So, it is asking us type of acute pancreatic collection. Now, whenever in a CT you are given a pancreatic section, so this is the pancreas right here. This is a pancreas. This is the spleen. This right here is the liver. And this is the gallbladder. Now, in a pancreas on CT, pancreas is intensely enhancing. It appears very bright on CT. So, this is the normal pancreas. This is the normal pancreas. And if there is necrosis in the pancreas, if there is acute necrotic pancreatitis, there will be hypodensity. So, this is hypodense area which suggests necrosis. Okay. And since only 10 days has passed, what type of a fluid collection will it be? It will be a acute necrotic collection. Okay. Remember, if in pancreatitis, acute pancreatitis, if it is necrosis present and necrosis absent. So, if there is necrosis present and the collection has duration less than 4 weeks, we call it acute necrotic collection. If it is more than 4 weeks, we call it walled-off necrosis. If there is no necrosis present and the collection is less than 4 weeks, we call it acute peripancreatic fluid collection. And after 4 weeks, there is a wall that develops surrounding this collection and we call it pseudocyst. Now, moving on to the next question, identify the imaging technique shown below. So, it is a pretty straightforward question. We zoom in to the image and what do we see? We see that the bones are bright. So, it is a CT image. And which is this artery that we see? This is the descending aorta. This right here is the descending aorta. And we see the celiac axis. And we see the superior mesenteric artery, right? Now, is it a CT angiography or a CT venography? Now, in this image, the descending aorta is appearing very bright. So, it is taken in the arterial phase of image. So, this is an example of CT angiography, right? Which of the following statement is not true about various isotopes used in scintigraphy studies? So, this is a nuclear medicine question. Let's approach it. So, the first option is HEDA scan is the investigation of choice for acute cholecystitis. Now, is it a right answer or a wrong answer? A lot of students might consider that yes, HEDA and acute cholecystitis are given in the question, so this might be the right answer, but it's not. It's asking the investigation of choice. Now, for acute cholecystitis, the investigation of choice is ultrasound. Okay, HEDA is the most accurate investigation, but it's not the investigation of choice. Okay, investigation of choice for acute chole is an ultrasound. So now, technetium 99M methylene pyrophosphate or NDP scan is used for bone scan. Yes, it is a correct option. Technetium 99M RBC scintigraphy is used to pick up intermittent bleeding in GIT. Yes, this is a correct option. DTPA is the agent of choice for GFR estimation. This is the correct option. So, which is the incorrect statement? It is option A. Now, we move on to the next question. A 35-year-old male presented with lower back pain with early morning stiffness. There was an improvement in symptoms as the day progressed. This is the plain X-ray that is shown in the image. Now, which sign is seen in this X-ray? Now, based on the history, a lot of you would guess that morning stiffness is given, a young age is given, and a low backache is given. So, it is an inflammatory type of low backache, and most commonly in a young male, ankylosing spondylitis occurs. So, what is the sign that we see in this X-ray? Yes, it is the bamboo spine. Okay, and we also see bony ankylosis of bilateral SI joints. Okay, so the answer here is an ankylosing spondylitis. Now we move on to the next question. A 55-year-old woman presents to her primary care physician complaining of persistent headaches and episodes of blurred vision. On further questioning, she reveals difficulty with memory and concentration and intermittent numbness in her right arm. So there is some weakness. On further evaluation, an MRI was done and that reveals a parafalcine mass with a dural tail sign. Now, whenever a question is given that there is an intracranial mass and there is a dural tail sign that is given, your eye should directly look for an extraaxial mass, and in a mid-elderly female, an extraaxial mass with a dural tail sign would be a meningioma. Okay. Now, arachnoid cyst, intracranial lipoma, epidermoid cyst, they do not have dural tail sign. Okay, dural tail sign is present in an extraaxial lesion, and in this case, a meningioma. Okay, so answer here is a meningioma. Okay. So that was all regarding the radiology questions for today's mock test. Thank you.